Please raise your hand if you can hear me. Thank you.
Doctor.
Thank you. So my name is Dr. Lucia Amolo. I'm a consultant pediatrician at the Kenyatta National Hospital. And with me as a panelist who will be joining later is Mr. Muthinji. He's a neurophysiologist and specialist in sleep studies in Kenyatta University. So today I'll be speaking about sleep and related disorders in children. So just to start off, recently we got a 6-year-old girl who came accompanied by her mother to the Kenyatta National Hospital Neurology Clinic with a 2-year history of excessive daytime sleepiness. The mother actually reported that she slept an average of 24 to 36 hours in a day. She actually said that sometimes she would sleep on Sunday afternoon and wake up on Monday evening. And the mother had gotten so frustrated that sometimes she had resorted to pouring a bucket of cold water to the girl in an attempt to wake her up. Her performance in school had dropped significantly as she often fell asleep in class. She'd had a history of febrile seizures at 7 months of life. She did not receive any treatment and had never convulsed subsequently. Her parents were separated, and on further probing, there was actually a history of domestic abuse by the father, and that's the reason they separated. She was an only child. So how would you proceed as the clinician in seeing this child? The second case is an 18-month-old baby who's currently admitted in the Kenyatta National Hospital pediatric wards. She has been on follow-up for dilated cardiomyopathy and adenotonsillar hypertrophy. She presented with a long-standing history of loud snoring when asleep, often waking up suddenly in the night gasping for air. The mother also reported that the child was excessively sleepy during the day, and she reports that these symptoms had worsened, which had necessitated the current admission. The child had been diagnosed with adenotonsillar hypertrophy at 7 months of life, and subsequently had developed dilated cardiomyopathy at, 12 months of life, and had been on follow-up at the KNH Cardiology Clinic, was on Lasix and Aldactone. So how would you, as the clinician, proceed in seeing this child? This is just something to whet your appetite. So this is my outline. I'll define sleep. We'll talk about the importance of sleep, regulators of sleep. I'll discuss the sleep-wake cycle, classification and management of sleep disorders in children. We'll discuss all of them because there are quite a number, just highlight a few. And then we'll have input from a neurophysiologist, that is Mr. Muthinji, and he'll tell us a bit on the local situation and the tests that they do. And then we'll have a Q&A session. So what is sleep exactly? Sleep is a behavior, and all mammals do it. It's actually a state where awareness to the environmental stimuli is reduced. Sleep is quite different from being comatose or unconscious because sleep is a reversible state while the others are not. Did you know that we actually sleep for a third of our lives? So sleep is actually a product of the brain by the brain. In the brain, we have what we call the reticular activating system, which are a projection of neurons that run from our brainstem all the way to the brain, that is the cerebral cortex, and they control the sleep-wake cycle without need for any external stimuli. So these neurons project all the way to various parts of the brain and determine whether we're asleep or we're awake. So why exactly is sleep important? Sleep is an opportunity for the body to conserve energy, restore normal processes, promote physical growth, as well as support mental development. And we can see the importance of sleep in situations like, for example, when you have an examination coming about and you've spent the last week reading for your exam and not sleeping, and you go to the examination room and the topic that you read the night before, you suddenly forget everything. And this just tells you why sleep is important, because it helps consolidate many processes, including our memories. It's the most recognized consequence of inadequate sleep is daytime sleepiness. And sleepiness in children commonly manifests as irritability, behavioral problems. You'll find your child is always throwing tantrums. The child will have challenges with learning in school. And for those who have a driving license, especially among the teenagers, you'll find that they have motor vehicle accidents and also poor academic performance. So distinguishing significant sleep disruptions from normal age-related changes can be challenging and can ultimately delay their treatment in the pediatric patient. So what does this mean? We know that children sleep more than adults do. In a newborn, they tend to sleep every 2 to 3 hours and just wake up to sleep. And in an infant and toddler, they usually have about 2 to 3 naps during the day. So they're usually lifetime changes that occur in the sleep-awake cycle. And if you're not aware of them, then you may wrongly diagnose a pediatric patient as having a sleep disorder. So there are so many neurotransmitters that regulate sleep. So this slide is just to highlight to you that many things would determine whether you're awake and listening to this presentation or you're dozing off. And some of the neurotransmitters I've highlighted for you. For example, when you're awake, we have neurotransmitters like acetylcholine, what we call the monoamines, which include serotonin, norepinephrine, histamine. We also have dopamine, hypocretin, and glutamate. When you're asleep, you exist in two phases. You can either be in non-REM sleep or REM sleep. REM means rapid eye movement. So in non-REM sleep, you'd have things like GABA and adenosine. For example, some of you may doze off during this presentation. You may be in light sleep. So your GABA and adenosine levels would be high. Or you can also just doze off completely and you go into REM sleep. And in REM sleep, the neurotransmitters would be acetylcholine and glutamate. So it's not so important to memorize these neurotransmitters, but just to highlight that it's a complex process that goes on in the brain that determines whether you're asleep or awake. And these neurotransmitters are what we call state-dependent or site-dependent. Now, what does state-dependent mean? It means that certain neurotransmitters will be released more when you're awake and others more when you're asleep. And what does site-dependent mean? If you look at acetylcholine, when you're asleep, it's released. When you're in REM sleep and when you're awake, it's also released. However, this acetylcholine will act on different sites of the brain to determine whether you're awake or you're asleep. And that is what we call site dependence. From the diagram on the left, you can see that most of these neurotransmitters being released for sleep are released along this area. And this area is what we call the brainstem. So defining behavioral states. As I've said, we exist in two states. We're either awake or we're asleep. And when you're asleep, you can be in either what we call REM sleep or non-REM sleep. REM just means rapid eye movement. So how did scientists and doctors determine what wakefulness and sleep is? How do you know that if you walk into your office and you find your colleague with their eyes closed, is your colleague just closing their eyes and relaxing? Is your colleague just having a light sleep, or is your colleague in deep sleep, or is your colleague in REM sleep? So there are three things that researchers have used to determine the state that you're in. First is skeletal muscle, second is eye movement, and the third is cortical activity or brain activity. I'll start with eye movement. When you're awake and looking around, your eye is taking in so much stimuli. So if you do what we call an electrooculogram, you'll see that it's quite active, as you can see here in the state of wakefulness. Now, when you're asleep, as I've said, you can exist in two stages, either rapid eye movement sleep or non-rapid eye movement sleep. When you're in rapid eye movement sleep, there'll actually be a bit of movement of your eyes, not as much as when you're awake, but it will be present. And when you're in non-REM sleep, there'll be no movement of your eyes. The interesting thing is that if you have a partner or if you have a little baby and towards the morning when they're having a long period of REM sleep, if you actually look at their eyes, you'll actually see the eyes darting back and forth, and that would indicate that they're in REM sleep. Another thing that we look at to determine which of these three states you're in is what we call electromyogram. So electromyogram looks at the muscular activity. Obviously, when you're awake, you're moving your limbs around, and if we do an EMG, we'll see a lot of activity, high frequency activity and high amplitude. When you're asleep, of course, your movement, usually you move from wakefulness to non-REM sleep. When you're in non-REM sleep, there'll be a bit of movement of your limbs, but not as much as when you're awake. And when you're in REM sleep, actually, it's a form of muscle atonia. Your limbs are paralyzed because the alpha motor neurons of the spinal cords are inhibited. And that's why if you walk into, for example, the NICU, or if you have a child who's sleeping, sometimes when you lift the hand up, you notice that it just falls suddenly. And usually if you find that happening, most likely this child is in REM sleep because they have complete paralysis of the muscle. The other thing that we look at is the EEG. The EEG will tell you activity of the brain. When you're awake, of course, the neurons in your brain are firing and sending all these signals. So you'll see a lot of high frequency, low amplitude waveform if you do the EEG. And this waveform is similar to what we get in rapid eye movement sleep. When you're in light sleep and deep sleep, that is the non-rapid eye movement sleep, then the brain activity starts switching off and you have this high amplitude, low frequency waveforms as the brain is doing less and less activity in order to restore its energy. So these are the ways that you determine whether a person is asleep or awake. And if they're asleep, if they're in REM sleep or non-REM sleep. So how is sleep organized? So organization of sleep occurs through this phase that I'm going to explain. We move through these three behavioral states throughout the 24-hour cycle. So first of all, you're awake and you're listening to Dr. Molo giving this presentation. As afternoon progresses, you start feeling a bit sleepy because she's talking for too long. So you go into your non-REM sleep. The non-REM sleep is divided into three phases: N1, N2, and N3. N1 is light sleep and N3 is deep sleep. Some textbooks go all the way to N4, which is very deep sleep. So you're awake and you immediately go to non-REM sleep. So N1, then you go to N2, then you go to N3. After you go to your non-REM sleep, after about 90 minutes, then you go to rapid eye movement sleep. Then again, you go to your non-REM sleep. Sometimes during the night, you find that you may awake for a brief period of time, then you go back to your non-REM sleep, REM sleep, so it keeps cycling. You might not always wake up in the night. Now, usually you find that most people dream during this REM sleep, during this period. And sometimes you may find that you don't really remember what you dreamt about in the morning. So most people who remember their dreams are the ones who have this brief period of waking up in the night. But if you just cycle between non-REM, REM, non-REM, REM, at the time morning comes, then you really won't remember your dream. So sleep disorders can occur due to dysregulation anywhere in this pathway. For example, we have what we call REM sleep behavior disorder. Remember that we said during REM sleep, you have complete muscle paralysis. So there's some people who, when they're in REM sleep, they begin to, and we said during REM sleep, you act out your dreams. So there's some people during REM sleep, they actually act out their dream. And if you have a partner who has REM sleep behavior disorder, then you might actually find that they're punching you and throwing blows all over the place because they have this REM sleep behavior disorder. Now, if you have narcolepsy, narcolepsy is a condition where you suddenly have an intense urge to sleep. For example, I may be talking to you and suddenly I just fall asleep on the table. So in narcolepsy, you move from this state of wakefulness to REM sleep. So you skip this non-REM period. And this is a disorder that occurs, that is commonly recognized in the pediatric population. Another example of a sleep disorder would be night terrors. Night terrors would occur if you move from deep sleep to sudden wakefulness without passing through the non-REM REM cycle. So when this happens, you'll find that you're suddenly awoken by your 3-year-old who's screaming at the top of their voice, saying that they've had a bad dream or a nightmare. So dysregulation in this sleep-wake cycle would usually cause sleep disorders. So just a little bit about non-REM REM sleep. So non-REM sleep, it occurs about 75 to 80% of the total time spent in sleep, while rapid eye movement takes 20 to 25% of the total time that you sleep. The average length of fast non-REM to REM cycle is 90 minutes. So the average length of time from the time you fall asleep to go to this REM period is 90 minutes. If you don't take this average time, then you have a sleep disorder like narcolepsy. Usually you'll notice that as you move along in your sleep cycle throughout the night, then the periods that you spend in REM sleep are slightly longer than the initial period of sleep. And that's why you'll find in the early morning, you'd be able to detect signs of REM sleep, like the rapid eye movement of the eyes and the paralysis of the hands, because it takes a longer period in the early morning. So REM sleep increases as the night progresses and is longest in the last third of the sleep episode. So this is just to highlight the brain activity that occurs during sleep. It's what I've highlighted you pick up in an EEG. So you can see when you're awake, you have this low amplitude, high frequency waveform, similar to what you see in rapid eye movement sleep. And when you're in this slow wave sleep cycle, that is the non-REM sleep, then you start seeing the high amplitude, low frequency, which increases as the brain switches off when you're in this deep sleep. That would be the stage 4 sleep. So next, I'll talk about a little bit about the circadian cycles. So most of the time when you hear about circadian cycle, it's used when you're talking about sleep. So we have a circadian clock within our brain that runs roughly every 24 hours. So there's a part of our brain that is called the suprachiasmatic nucleus. Now, this suprachiasmatic nucleus lies in the anterior hypothalamus. It contains a molecular inbuilt clock that controls our sleep-wake cycle. So this suprachiasmatic nucleus usually receives input from the retina, that's the eye. So usually during the day, there's light. So signals will be sent from the retina all the way to the suprachiasmatic nucleus, and it will tell us that it's daytime and we need to stay awake. When evening comes, it becomes dark, and we no longer have signals going to the suprachiasmatic nucleus, and then the body is told that it's evening, it's time to switch off, and that is what will cause you to sleep. So this is what is the circadian rhythm. Now, what evidence we have to show that we have these cyclic 24-hour changes that occur in human beings? We have done studies in mammals, rats, unfortunately, the ones that are commonly, fortunately or unfortunately, the ones that are commonly subjected to studies. So when we've done studies, we see that when we look at body temperature, the body temperature usually is quite high during the day. So in the morning, your body temperature will go up. And then as evening comes around 10, 11 o'clock, your body temperature starts to drop. Throughout the night, it remains low. And then again, as the day progresses, it goes up. And this cycle is repeated every 24 hours. Again, growth hormone, for those of you who work in a hospital setting, you will commonly hear the doctors say, I want my cortisol and growth hormone levels at 6 a.m. and 6 p.m. Why do they ask for this? Because we have cyclic changes in the growth hormone and the cortisol levels. We find that our growth hormone levels are quite low during the day. As the night approaches around 10, 11, your growth hormone goes up. And then as the night continues, it starts going down. And by morning, your growth hormone levels are down. Same for cortisol. So cortisol levels would tend to be low. So during the morning, they start quite high. And then as the day progresses, you gradually have a drop in your cortisol levels. By nighttime, around midnight, your cortisol level is at the lowest. It remains low. And then as morning progresses, your cortisol level begins to go up. So this shows that we have some sort of 24-hour clock that's going on in our body that's telling us, hey, it's time to wake up, it's time to go to bed. And this is what we call the circadian rhythm. So the circadian we have both the hemostatic rhythm and the circadian process. So for the hemostatic process, this is the drive to sleep that is influenced by the duration of wakefulness. So the longer you are awake, then this homeostatic process tells you that, hey, it's time to sleep, and it keeps increasing until around 9, 10 when you go to bed. And then as you sleep, then the hemostatic process starts to switch off and it tells you that it's time to wake up. Now for the circadian rhythm, it's opposite. When there's bright lights and signals are passing through the retina into the eye, they're telling you you need to stay awake. During around 3, 4 p.m., like right about now, some of you may doze off because your circadian rhythm will go down a bit, and then it goes up again. And then as evening approaches and it starts getting dark, you find that your circadian rhythm switches off and you have to go to bed. Now, in this diagram, you can also see melatonin. Melatonin is a type of hormone that's released by all human beings. You find that your melatonin level usually goes up in the night. It peaks around 3 to 4 a.m. It's at its highest, and then it starts going down again. I'll talk about melatonin in the next slide, but what melatonin does, is that it helps you initiate sleep. So melatonin is an endogenous hormone. It's produced by the pineal gland. Nocturnal secretion begins in the nightfall and peaks at around 3 a.m. Secretion is usually suppressed by light. So as day approaches, the suprachiasmatic nucleus will switch off the production of melatonin. The main role of melatonin is regulation in the regulation of sleep. So it's in the timing of sleep and the circadian rhythm control. Melatonin will tell you, hey, it's time to go to bed. However, it doesn't prolong the duration of sleep, but it's very important in the initiation of sleep. Now, sleep problems occur when melatonin secretion is disturbed. And we have seen this particularly in autistic children. A study has been done by O'Hare et al. And what they found is that many autistic children would usually have low levels of melatonin. And that's why we find that many autistic children are usually given melatonin to aid in their sleep. We have what we call ralmetion, which is a melatonin agonist that has been given in adolescents and older children and has been shown to assist autistic children in the initiation of sleep. So we can't talk about sleep without talking about the changes in the sleep rhythm that occurs across the lifespan. Newborns have what we call an ultradian rhythm. An ultradian rhythm means that your newborn is awake for about 2-3 hours, then sleeps. So they wake up, feed, sleep for 2-3 hours. And this occurs throughout the newborn period. At around 11 weeks, then the circadian rhythm begins to kick in. And when this happens, then you find that your newborn is now having longer periods of sleep at night. And then during the day, they have, by the time a child is 1 year old, during the day, they have about two daytime naps. And this occurs in the typical child. I say typical child because not all children follow this rhythm. If you have children like mine, they completely refuse to sleep during the day. And if you have children, you know how important it is for this daytime nap because it gives you a chance to escape. Otherwise, you have to hide in the bathroom if you want to get some peace. As the child gets older, around 4 years, you find that they are able to sleep for a longer period during the night, and then they just have one daytime nap. And by the time the child is 10 years old, the circadian rhythm and the hemostatic processes are well developed, and you find that the child really does not have to nap during the day and follows a general, well-defined sleep pattern. And then as you get older, you see that adults have just a very short period of sleep, around 6 to 8 hours of sleep. So I don't know where you fall in this scale. Some of you might still be having this ultradian sleep rhythm where you keep dozing off. Many of us have this 4-year-old rhythm where we require our afternoon nap. So you can see that you need to understand the changes that occur in the sleep rhythm across the lifespan so that if you detect a disorder in a 1-year-old or a newborn, you need to know what is normal so that you don't treat what is normal. So how do you assess sleep in children? There are several things that you can do. Number one is keeping a sleep diary, taking a thorough history, physical examination, what we call polysomnography, and actigraphy. I'll touch on each of them. I hope Mudhinji has joined us. He's a neurophysiologist, so he should be able to tell us more about polysomnography and actigraphy. So what's a sleep diary? A sleep diary is basically a diary that the parent keeps in order to determine. So if you have, for example, your child, remember the case that I gave of the 6-year-old who the mother reported was sleeping for 24 to 36 hours in a day, and she was very distressed. This child was not able to perform well in school. Then you need to tell this mother to at least keep a sleep diary for 2 weeks. So what are some of the things that you record in the sleep diary? What time did the child go to bed? This is an example, like this child slept at 10:15 p.m. So there's a difference between going to bed and trying to sleep. A lot of us go to bed, but especially the teenagers, you're on your phone. But when you put the phone down, that's now when we say that you're trying to go to sleep. So what time did you try to go to sleep? How long did it take you to fall asleep? And most of the time, this would be documented by somebody who's observing the child. How many times did you wake up, not counting your final awakening? In this particular child, they woke up 3 times in the night. So is this normal? Of course, this will depend on the age of the patient. If it's a newborn, then it would not be unusual. But if it's a 10-year-old, then it is unusual if you find that they're waking up 3 times in the night. In total, how long did these awakenings last? What time was your final awakening? What time did you get out of bed? Remember, you can wake up, but how long does it take you to get out of bed? And then you ask the patient to rate the quality of the sleep. Was it very poor, fair, good, or very good? So ideally, when we sleep and wake up, we need to feel refreshed. And then, of course, comments. For example, this particular patient said that they have a cold. So when you're documenting your sleep diary, you need to write the date, the day of the week, and the type of day. Was it a weekend or a weekday? Was it a school day? Was it a vacation? Or had you taken a day off? Then, for example, in this particular diary, we tell the patient to put the letter C in the box where you have coffee, cola, or tea. We have what we call inadequate sleep hygiene practices. For example, some of us like to take coffee before we go to bed, which is not a good thing because it will cause insomnia. You need to document any medication that the patient is in. For example, some patients who are on antidepressants, what we call selective serotonin reuptake inhibitors, they will cause insomnia. If you remember the neurotransmitters that I mentioned, serotonin is responsible for keeping you awake. Some patients like to take, for many of us usually take antihistamines, and we know some antihistamines can make you drowsy. And then, of course, you can tell the patient to put an A if you're drinking alcohol and put an E when you exercise. Of course, if you're going to be doing vigorous exercises before you go to bed, then you're likely to have insomnia. Then you put a line to show where you go to bed. So this is just an example of a sleep diary, and we like to keep it for a 2-week period so that we can have an accurate picture of what this patient is going through before we decide to treat the patient. Then you need to take sleep history. Do you have any concerns regarding your child's sleep? Does your child take more than 30 minutes to fall asleep at bedtime? Once asleep, does he stay asleep? Does your child seem excessively sleepy during the day? Have you ever had your child snore or stop breathing at night? So this is just a snapshot of a few of the questions that you'd want to ask when you're taking a history. But we need to take a thorough history, including the presenting complaints, the history, the past medical history, the nutritional history, immunization history, family social history, because you may have a history of narcolepsy in the family. So basically take a very detailed history. So another thing that would be important in assessing sleep is what we call polysomnography. So polysomnography is the gold standard assessment tool for sleep disorders. It is done in some places in Kenya. Mudhinji will talk to us a little bit about that. So polysomnography looks at the 3 things that I talked about. The EEG, which will distinguish whether you're awake or you're in non-REM sleep or REM sleep. The EOG, I hope you remember what we talked about the EOG. We said in REM sleep, you have rapid eye movement. And when you're awake, you also have eye movement. But when you're in non-REM sleep, you do not have any movement. And then, of course, we talked about the EMG. We said when you're awake, the EMG will be very active because you're moving your limbs. As you progress to non-REM sleep, then the movement reduces. And when you're in REM sleep, you have complete atonia of the muscles. Other things that are important to look at when you do a polysomnograph, at the ECG, you need to look at your heart and how it's beating. You need to look at airflow if possible. Video recording would be good. For example, if you're treating a patient who has insomnia, you want to see that as you do your polysomnograph and look at all these things, is this child awake or asleep? If this child has a REM sleep movement disorder, is this child moving the limbs around? You want to record any additional sounds that may be in the room. Some of us like to sleep with the TV on, and of course, this may be factors that may affect your sleep pattern. You want to look at your respiratory rate, your SpO2s, and the position of the body during sleep. Remember, if some children who have adenotonsillar hypertrophy may be unable to sleep flat on their bed, or they may like to sleep with their airway hyperextended in an attempt to allow air to enter the airway. We have what we call multiple sleep latency tests. Now, these are a series of recordings to monitor a person's sleep pattern. They're used to see how quickly a person falls asleep during the day and how often one goes into REM sleep. Remember, we said that the average time it takes for one to go into REM sleep is 90 minutes. So if a person has narcolepsy, they'll be awake, and then within 5 minutes, they have gone into REM sleep. And you'd be able to distinguish this by doing your polysomnograph and your multiple sleep latency test. So the multiple sleep latency test usually involves taking 5 20-minute naps 2 hours apart, and you document so that you can be able to detect any errors that may be occurring. We have what you call actigraphy. Mudinji did tell me that this is available in Kenya. It's an objective assessment of circadian rhythms that is done. So usually involves monitoring the active and inactive times during a 2 to 4 week period to get an overview of the sleep and wake times and to determine if the patient has delayed or advanced sleep phase rhythms. It's worn in the non-dominant hand. Of course, it would be cheaper and less cumbersome than a polysomnograph, and it has a higher compliance. This is an example of a normal actigraph. You can see that it records a lot of movement when the patient is awake, but as the patient falls asleep, you have less movement. And you can see from this, roughly the patient tends to fall asleep around the same time every day, 11 to 12, and wakes up around 7 to 8 o'clock. So this is an example of a normal actigraph. So now that we know what sleep is, we know how to determine, we know the various stages of sleep, and we know what we need to ask when we are determining if there's a sleep disorder. We'll move on to discuss classification of sleep disorders in children. Because it's very extensive, I will just touch on it a little bit. We use the DSM-4 criteria or the ICD-10 classification when we are classifying sleep disorders in children. We have sleep-related breathing disorders, insomnia, hypersomnia, circadian rhythm sleep disorders, sleep-related movement disorders, parasomnias, and other sleep disorders. So I'll discuss each of them. So we'll begin with sleep-related breathing disorders. You can see a diagram of a child with very huge, what we call kissing tonsils. They're almost touching at the center. So this is a child who would present with, like the case I had presented before, obstructive sleep apnea. So we classify them into 3. You can have obstructive sleep apnea, central sleep apnea, or sleep-related hypoventilation. Obstructive sleep apnea, which I'll talk about in the next slides, would occur if you have anything that causes obstruction to the passage of air into the lungs. And I'll discuss this a bit more. Central sleep apnea occurs when you have challenges with your respiratory center, which lies in the brainstem. For example, if you have chain-stocks breathing, then you'd have a problem with regulating your breathing, which is central. If you have a child who has anal Chiari malformation, that is when you have herniation of the brainstem and the cerebellum through the foramen magnum, then it pushes on the brainstem and is likely to cause central sleep apnea. We have conditions like sleep-related hypoventilation. Obesity is becoming a pandemic, especially in the pediatric population. So this can cause obstruction to the movement of air into your lungs. And children with neuromuscular disorders such as spinal muscular atrophy or the dystrophinopathies, then they may have challenges moving with respiration, they cannot breathe in and out adequately, and they're likely to have hypoventilation or ventilation perfusion mismatch. So the sleep-related breathing disorders are all associated with impairment in this ventilation. This causes a buildup of carbon dioxide, which we call hypercarbia, or we have reduction on oxygen, which we call hypoxia. And when you have a lot of carbon dioxide in the brain, this acts in the brain respiratory center to try and compensate. So the patient tries to take in a deep breath to compensate for this. So usually if you have a reduction in airflow for at least 10 seconds, we call this apnea. If you just have reduced airflow, we call this hypopnea. So the frequency of events per hour of sleep is called the apnea-hypopnea index. And it's a measure of the severity of obstructive sleep apnea. So if you have a patient who's waking up 10 times in the night with episodes of at least 10 seconds of apnea, then we give them an apnea-hypopnea index of 10, and it assists us in measuring how severe this is. So I'll touch on obstructive sleep apnea, which is actually the most common cause of sleep disorders in children. The etiology of obstructive sleep apnea is multifactorial. For example, you may have adenotonsillar hypertrophy, structural factors, and craniofacial abnormalities. For example, in this diagram, you can have a micrognathia or a retrognathia. You can have a large tongue, which you call macroglossia. You can have adenotonsillar hypertrophy. You can have nasal obstruction, for example, choanal atresia. All of this will cause obstruction of air from entering the airway. And if the patient is asleep, then they'll have a buildup of carbon dioxide and reduced oxygen, and this will force the patient to wake up suddenly in an attempt to take a breath. So we can also have obesity, as I've said, that's becoming a pandemic. Neuromuscular disorders, I've mentioned spinal muscular atrophy, Duchenne's muscular dystrophy, which can cause problems with the airway, cerebral palsy, and genetic disorders, for example, patients who have Down syndrome. So in a normal non-obstructive airway, you can see air is able to move in and out of the airway. But if you have obstructive sleep apnea, then you find that you have an obstruction and you have your buildup of PCO2. So what are the symptoms of obstructive sleep apnea? You'll have gasping, snotty noises like this patient. You'll have apnea, you'll have bedwetting. This patient will sleep in a seated position or with the neck hyperextended. You will have cyanosis, headaches on awakening, excessive daytime sleepiness, attention deficit hyperactive disorder, where you find that this patient is in class but cannot sit still, learning problems, or cardiovascular dysfunction. For example, the patient that I mentioned to you at the beginning who had adenotonsillar hypertrophy, because of the hypoxia and hypercarbia, you have increased pulmonary resistance, the heart tries to compensate, and you end up having a dilated cardiomyopathy. And that's why you find a lot of patients with adenotonsillar hypertrophy who are not treated for a long time end up having cardiovascular dysfunction. So how do you assess the severity of obstructive sleep apnea? We have what we call the Malampati score, where you ask the patient to open the mouth. It's graded from class 1 to class 4. In the diagram, you can see this patient has class 4, where you cannot even see the soft palate. In class 3, you can only see the base of the uvula. In class 2, there's complete visualization of the uvula, but it's not as good as in the class 1. So I'd like you all at the end of this presentation to just go in front of a mirror. If you're having problems sleeping, open your mouth and try and classify yourself so that we can see if you may be having a problem with your sleep. So what happens in obstructive sleep apnea? So this little boy is trying to fall asleep. As he's lying down, the airway becomes obstructed. He has a buildup of carbon dioxide, reduced oxygen. So just as he's about to go into stage 1, non-REM sleep, the lack of oxygen and the hypercarbia forces the patient to wake up suddenly, to take a deep breath, and the patient wakes up. The patient attempts to sleep again. They only manage to get to stage 1 sleep because of the excessive carbon dioxide. they wake up again. And this cycle continues throughout the night. And you can see even they may have shortened periods of sleep. So you find your patient throughout the night has barely been able to move from stage 1, which is the light sleep, to stage 4, which is the deep sleep. And that is why you find that this patient during the day will have excessive daytime sleepiness, and during the night will have a sleep-related breathing disorder. So how do you treat sleep-related breathing disorders? Of course, it's based on the etiology. If you have adenotonsillar hypertrophy, you want to take out your tonsils. This is not done commonly in our setting, or rather I've not seen it done in the pediatric patients, but you can do uvulopalatopharyngeal surgery, where if you find that the patient is constantly having problems with breathing at night, you take out your uvula and you take out a part of your soft palate in order to keep the airway patent. Now, in the older population, such as adolescents, we can use what we call continued positive airway pressure, where this pressure forces the airway to remain open during inspiration and expiration. So all patients who snore, especially in the pediatric population, should be investigated. I'll move on to talk about insomnia. Insomnia is one of the most common sleep disorders, and it's characterized by difficulty in falling asleep or staying asleep. It can be primary or secondary. Primary insomnia occurs when you don't really know the cause of the insomnia. Secondary insomnia occurs due to medications. For example, I talked about the SSRIs, which contain serotonin. We say that serotonin is one of the neurotransmitters that is involved in keeping you awake. So you find that a lot of patients who are depressed and are put on SSRIs will actually have insomnia. So this is something that the psychiatrist or the pediatrician should have in mind. If you get an adolescent coming with complaints of insomnia and they're depressed. Medical conditions, we've talked about autism and ADHD. These patients have problems in initiating sleep. They have problems in their circadian rhythm. So they'll tend to have insomnia. Insomnia can be classified as short-term or chronic insomnia. Short-term insomnia would occur, for example, in adjustment insomnia, loss of a loved one. We're going through the COVID period, so we know that death is commonly occurring, and we're finding a lot of adolescents and children who are coming in with insomnia because they're unable to cope with this loss. You can have chronic insomnia. Again, it has various classifications. We have psychophysiological insomnia. We've all been through a job interview or an examination. You're so anxious, you can't sleep the night before. If you're stressed, if you're depressed, you also are likely to have insomnia. And if you don't seek treatment, then this becomes a chronic problem. Inadequate sleep hygiene. Now, this is very common, not just among adolescents, but all of us. How many of us take coffee before we go to bed? If you're like me, you like to watch Korean movies before you go to bed, and sometimes you find yourself staying up until 2 a.m. watching the movies. Extreme of temperatures. Now it's the cold season. We find a lot of us are very cold. It's very cold, so you can't really sleep well. Or sometimes when you're in a very hot temperature, those of you who like vacationing in Dubai, sometimes you find it's so hot you can barely sleep if you're not used to the weather. We know a lot of teenagers like to club and to go out every night, especially during the vacation period. So of course, this will interfere with the circadian rhythm. And when they are forced to, you may find that they're not going out. You may find that these kids actually have a problem falling asleep. Behavioral insomnia of childhood. Again, this is a very common problem in children, especially the toddlers and infants, where you find that your child cannot go to bed unless you are present in the room. And if this continues for a long time, then you find your child will never go to sleep unless the parent is present in the room. Or sometimes you find you're so used to sleeping with the child that when you go on a trip, then the maid calls you and tells you, huyu mtoto wako amekataa kulala. So it's good to know some of the things that can cause insomnia. If you have your sleep diary and you take a good history, then you should be able to detect. Some of the signs and symptoms of insomnia would be irritability, fatigue, excessive daytime sleepiness, poor school performance, and problem behavior in children. So how do we treat insomnia? We have pharmacological and non-pharmacological treatments. Of course, you treat the underlying condition, remove offending medication if need be, sleep hygiene, Avoid vigorous exercise before you go to bed. Avoid coffee, Coca-Cola, alcohol before you go to bed. Set bedtime routines for your child. Minimize TV, LCD, LED exposure. I think we're all guilty of using our phones before we go to bed, and this is becoming a common problem in teenagers and young children. You need to reduce emotional and behavioral stimulation at night. Make sure that your child is not used to having you in the room before they go to bed. Try and get a routine for them so that they're able to take themselves to bed. Elimination of association between sleep and prerequisite conditions. Does your baby have to take a bottle of milk before they sleep? Are you co-sleeping with your baby? Have you gotten your child used to sleeping on the couch? So these are some of the habits that you need to break. Structural behavioral programs should be improved, such as avoiding pre-sleep disturbances, encouraging the child to fall asleep alone, avoiding night waking. Like if your child is used to waking up at night, then you need to avoid this, keep the lights off, and avoid co-sleeping, which I know may be difficult for some of us. And of course, I've mentioned sleep diaries so that we're able to detect any issues. We have non-pharmacological therapies. Bright light therapy can be used for the treatment of insomnia. It can also be used for the treatment of circadian rhythm sleep disorder. So we've talked about the circadian rhythm. So you reset your circadian rhythm back to normal in those with disturbances. So what do? You expose your eyes to intense but safe amounts of light for a specific and regular amount of time. Artificial light may be used to affect the body clock in the same way as sunlight. So usually if you find that you're having a patient who has a lot of insomnia, then you can try and use a bright light so that you can force them to go back to the circadian rhythm. And remember, we say that the circadian rhythm is usually affected by light. So we also have pharmacological agents that are used in the treatment of insomnia. If you remember the neurotransmitters that I talked about, the ones that promote wakefulness are our monoamines, dopamine, norepinephrine, histamine, acetylcholine, orexin, and glutamine. So you want to ensure that any drugs that the patient has do not have this. And the drug, we have the neurotransmitters that promote sleep, such as GABA, adenosine, melatonin. So you want to ensure that your patient has more of this. So short and intermediate acting benzodiazepines may be used. Benzodiazepines encourage the release of GABA. GABA is gamma aminobutyric acid. It's an inhibitory neurotransmitter. It promotes sleep. So they can be used. However, we try and avoid using benzodiazepines because we know they can be associated with dependence and they can be associated with long-term problems. We have non-benzodiazepine hypnotics, which are likely to have less side effects. For example, we have the drug called zolpidem. Ralmeterol, I mentioned, is a melatonin agonist, which will assist in initiation of sleep. Tricyclic antidepressants have been used off-label for sleep, and also anticholinergic drugs. So tricyclic antidepressants sometimes have anticholinergic effects. And we say acetylcholine is one of the drugs that promote wakefulness. And then, of course, antihistamines. Again, these two I've put a question mark because it's off-label use. We don't like using antidepressants and antihistamines for promotion of sleep. And remember, sometimes you take an antihistamine and you find yourself being drowsy. So these drugs can be used, but they're not really recommended. So just as a break, I'd like to talk about zolpidem, a drug that awakens the dead. So there is a patient known as Louis Villejon, who 3 years before, that's in 1999, was declared vegetative after he was hit by a truck and had taken to clawing his mattress during the night. So this is him. He was vegetative, he was always unconscious, and he was noted when he was in hospital that he was always clawing in his mattress asleep. So the doctors thought that he was suffering from insomnia. So what they decided to do is to give him zolpidem. Sorry. And I mentioned that zolpidem is one of the non-benzodiazepine drugs that can be used to treat insomnia. So actually, when the mom first administered the zolpidem, he was noted to suddenly stir and woke up. And this is a patient who had been unconscious for 3 years. And his first words were actually, "Hello, mommy." A few hours later, He went back and became unresponsive. But the next day, when the mother gave him zolpidem again, he woke up. So this is a drug that has elicited a lot of debate. It's a drug that has been attempted to reverse those who are unconscious or comatose, but it has not been consistently used. So this is something interesting that you can read about the drug zolpidem. So now I'll move on to talk about hypersomnias. Hypersomnia is basically excessive sleepiness. It's an inability to stay awake or alert during major waking episodes, resulting in periods of irrepressible need to sleep or unintended lapses into drowsiness or sleep. So hypersomnia is basically you cannot resist the urge to sleep. There are various classifications of hypersomnia. I'll talk about narcolepsy. Narcolepsy can be with or without cataplexy. What this means is with cataplexy, in patients with narcolepsy with cataplexy, usually high emotional states. For example, you may be in a room, a patient with narcolepsy with cataplexy may burst out laughing, and suddenly when they're laughing, they fall asleep suddenly and they go into REM sleep. We have menstrual-related hypersomnias. We have hypersomnias due to medical conditions such as obstructive sleep apnea, hypothyroidism, hepatic encephalopathy, hypersomnia due to medications. And again, this is why it's important to take your history to see if your patient is taking any medications. We have what you call Klein-Levin syndrome, which is a syndrome that not so common syndrome, but it affects boys, and it's characterized with excessive appetite and excessive sleepiness. Then we have primary hypersomnia, where we cannot really get the etiology of the excessive sleep. So I'll just play this video. This is a patient with narcolepsy. You can see that she's playing with her friends. They're playing badminton and she's laughing. And when she's laughing, she suddenly falls to the ground and falls asleep. So this is what we call narcolepsy with cataplexy. So narcolepsy can become recognized in children as young as 5 to 6 years of age, and delays in diagnosis are understandably common because we said that children usually sleep more than adults. It's characterized by extreme daytime sleepiness, marked by recurrent episodes of an irresistible need to sleep, unintentional sleep episodes. You may have gone for a meeting and then you suddenly fall asleep. As I've mentioned, it can come with or without cataplexy, which is a sudden loss of muscle tone with preserved consciousness, and it's commonly brought about by emotional experiences such as laughing. And it's commonly associated with what we call hypnagogic, hypnopompic hallucination. What this means that you hallucinate just before you fall asleep or just before you wake up. The reason for this is not clearly known. So narcolepsy is thought to be due to a mutation in orexin hypocretin system, which promotes wakefulness and promotes onset of REM sleep. If again you remember my neurotransmitters, I mentioned orexin hypocretin, which is involved in keeping patients awake. So these patients have a problem in the hypothalamus that produces this hypocretin. So how do you diagnose narcolepsy? You do a lumbar puncture and you check for your orexin levels. You do your multiple sleep latency test. I hope you remember what that is. And you also do your polysomnography. Usually if you do a polysomnography and you find that this patient goes quickly into REM sleep, usually with less than 15 minutes, then that's diagnostic of narcolepsy. Again, remember I said REM sleep should take at least 90 minutes before onset. So how do we treat narcolepsy? Again, back to these neurotransmitters, you give stimulants like methylphenidate, dextroamphetamine, modafinil, sodium oxybate, which basically increase these neurotransmitters. Antidepressants have been used to treat the cataplexy. Behavioral and lifestyle modifications such as scheduled naps, good sleep hygiene, and healthy diet and exercise to prevent obesity. So next, I'll talk about sleep-related movement disorders. Last week, I got a consult from a friend of mine whose neighbor had this issue, sorry. So you can see this is a 1-year-old, is deep asleep and is constantly banging the head. So this is an example of what we call sleep-related movement disorders. So sleep-related movement disorders are basically abnormal movement that occurs in sleep. There are various classifications. We have what we call sleep-related bruxism. So this is a common occurrence in children. It occurs around 2 to 5 years of age. What is bruxism? It's grinding of the teeth. Some of you may have children, when they're asleep, you notice that they're just grinding their teeth as they sleep. So this is usually a benign condition. It tends to go away as the child gets older. Treatment remains controversial. Some people advocate for the use of mouth braces if the grinding continues for a long time to avoid development of cavities in these patients, but this is controversial. For most patients, it usually goes away. We have sleep rhythmic disorders, for example, head banging, body rocking, or head rolling. In some patients, it can be pretty severe and pretty alarming for the parents. Actually, for many of these sleep rhythmic disorders, as the patient gets older, then it usually disappears. However, sometimes there's a risk of injury for your patients. So if you find like the head banging or body rocking is quite severe, what you do is then you must ensure that your baby sleeps in a safe place, and you may actually need to get a helmet for them to wear to avoid severe injury. We have what we call restless leg syndrome. I'm sure you've heard of this, where when a patient is asleep, they just have this impulse to move the leg. It's thought to be due to a deficiency of iron in dopamine neurons in the substantia nigra pars compacta. This is a part of the basal ganglia. If you read, then you'll know that basal ganglia is involved in controlling movement in human beings. So if you have, it's thought to be due to iron deficiency, iron supplements have been thought to help in treatment of this condition. Then we have sleep periodic limb movement disorders. Some of you who have spouses, they complain that occasionally you throw your legs, and they may think that maybe you've had a disagreement and you're trying to beat them during the sleep. So they may actually be having a sleep period limb movement disorder. And then we can also have sleep-related leg cramps. Now, parasomnias. Parasomnias are undesirable physical events or experiences that occur during sleep. It's more frequent in childhood than adolescence or adulthood. I'm sure some of you have experienced some of this. We have confusional arousal, where the child is moving around and moaning in the sleep, and then it can evolve to agitated behavior, like the child crying or calling out for their parent. We have sleepwalking. Again, sleepwalking, usually the child is completely asleep. The child will appear, usually in confusional arousal, the child will be agitated, but in sleepwalking, the child is very calm. Of course, if your child has the problem of sleepwalking, you must ensure that it's a safe area. The windows should be closed, if preferable, if they can sleep in a downstairs bedroom because of the risk of injuries. We have night terrors. Night terrors, we said, occur if a patient moves from a non-REM sleep to the waking up period without passing their REM. So typically the child will wake up screaming suddenly with intense fear. We have REM sleep behavior disorders, which we talked about. They're uncommon in children and tend to be quite dramatic, violent dreams. And you find that the child will be acting out the dream, and injury can commonly occur. We have nightmare disorder, where during the REM sleep, this patient has vivid dreams. You know, a lot of children would complain of monsters coming to attack them. There's an intense feeling of terror and dread that awakens the child from sleep. And then we have what we call recurrent isolated sleep paralysis, which begins in childhood or adolescence mostly. It's inability to speak or move that occurs during the transition period between sleep and wakefulness. And typically it lasts just a few minutes. For the treatment of parasomnias, it's largely reassuring the parents that parasomnias are common in childhood and can be managed effectively. You need to counsel the parents when instituting safety measures, for example, for those with sleepwalking or head banging, asking the parents to maintain a sleep log to record sleep periods, sleep arousals and awakenings, and any movement and behavior disorders, because we know all these things can affect a child during the day. The child can be hyperactive, can be disruptive in school, or can even have problems with excessive sleeping in school. And then sleep studies may be necessary to further monitor parasomnia events. And it's good to do these sleep studies with videography. So I'm almost coming to an end. I'll talk about circadian rhythm sleep disorders. These are rhythms that These are disorders that cause a disruption in your circadian rhythm. We've talked about the circadian rhythm, which during the day, the retina is taking on light. It goes to the suprachiasmatic nucleus and it tells you you need to stay awake. At night, because there's no stimuli from the suprachiasmatic nucleus, then you fall asleep. Of course, now this would be common more in adults, adolescents who are working at night. For many of us, we are medics, so we find that we have to work in the night. And of course, if you do this long term, it will affect your circadian rhythm. And that's why you'll find like you've done 4 nights and then you're on a day off, but you just find that you cannot sleep and you cannot rest. So this is a common disorder in people who are working in the medical field. We have delayed sleep phase type, where the sleep pattern is delayed for 2 hours or more from a conventional sleep pattern. For example, if your child typically sleeps at 7 p.m., you'll find that by 10 p.m., your child is still awake. Advanced sleep phase type is the opposite. It's characterized by recurrent patterns of early evenings. If your child sleeps at 7 p.m., you find that at 5 p.m. is when they're going to bed, and this child also tends to wake up much earlier. Then we can have irregular sleep-wake cycles, and then we have free-running type, where the sleep pattern is not adjusted or entrained to the 24-hour cycle. So this patient doesn't follow the typical circadian rhythm. I'll talk a little bit again about, again, with autism spectrum disease. This is common in pediatric patients. You find that they have circadian rhythm disorders. They have the delayed sleep phase, where they take a long time to fall asleep. They have irregular sleep-wake cycle, where you find that this child is constantly waking up in the night and falling asleep, waking at night, falling asleep. They rarely have the advanced sleep phase cycle, which means that they go to bed earlier. So for the autistic patients with the circadian rhythm disorders, how do we treat them? We give them melatonin or melatonin agonists like the ralmetion I mentioned, which helps them initiate sleep. We can do bright light therapy, which I mentioned, again, to force them back into the circadian rhythm. And then behavioral approaches such as avoiding blue light and soundproofing the rooms. And then to finish off, I'll talk about drug-induced sleep disorders. This is something that's becoming quite common in the pediatric population. If you walk around where I live in South Sea, you'll commonly see groups of teenagers sitting and enjoying their substances, and you find that these people you'll tend to find that these are the people who will be having problems with sleep. They'll be enjoying chewing their mogoka and cats, and then you find that this teenager will be having insomnia. We find that opioid use, abuse, and dependence, again, is becoming something very common, especially in the coast. You find that these drugs are relatively easily accessible to our teenagers, even in schools. Sometimes you find teenagers going to school share these drugs among each other. Sedatives, I've had patients and you wonder where they got access to the benzodiazepines, cocaine use, abuse, dependence, and other stimulants use, abuse, dependence. We know that these drugs can cause insomnia, parasomnias, they can cause circadian rhythm sleep disorders, and many more disorders of sleep. So it's up to us as clinicians and as parents to monitor our children to ensure that they don't have access to these drugs that can interfere with the sleep cycle. So I'm sure for many of us, our adenosine levels and our GABA levels are going up and our monoamines are going down. So I think it's time for me to conclude. And I'll conclude by telling you that we must all ensure that we always have a good night rest. I'll now open the floor to questions and answers. Before that, I don't know if Mudinji is with us. I'll ask him to put in a word or two.
Hello, thank you very much, Dr. Amolo. Can you hear me?
Yes.
I'm audible. Yeah, okay. Yeah, thank you very much. That was very comprehensive talk, and you've covered a lot of information and not very much to add. Just a few comments. One is to expand on the classification of the sleep disorders. The International Classification of Sleep Disorders 3, which was 2014, I think it's the most current, would classify them, as you said, in 7 categories. But obviously this comes from four complaints. Usually people with sleep disorders will either present as having insomnia, that is they can't initiate sleep or they can't maintain sleep, or they complain of hypersomnia, sleeping excessively, whether it's during the day or they have very prolonged night sleep, or they may have parasomnia, as you slightly said, where their sleep is disturbed, all have issues with circadian rhythm. And out of these 7 categories, I would have identified about 3 entities. So it's quite interesting to see that even though we may think of insomnia, parasomnia, hypersomnia, there are very many inbuilt entities which need to be considered. And so that's why polysomnography becomes an important aspect, because then it can help in trying to tailor down, to tail down to specific issues that may be involved with the particular patient. Now, I know you mentioned that quite rightly that the basis of polysomnography is 3 parameters, which is EEG, EOG, and EMG. That is the basic polysomnography. But that only
I think we may have lost you a bit.
Oh, have you lost me?
Yes, you disappeared a bit.
Hello, am I there now?
Yes, you are.
Yeah, so I was saying, so the polysomnography is basically those 3 parameters you mentioned, which is EEG, EOG, and DMG. But obviously, what this gives us, it gives us sleep architecture. It tells us how much you're able to sleep and whether you are able to do the right cycling of sleep in the night. The question though may be, what?
I think we lost you again. You're disappearing a bit.
I
Maybe
think
you move
maybe.
near the mic. Yes.
Okay, yeah. Keep prompting me if I get lost. So, the thing that I wanted to mention is, when we look at sleep disorders, it's quite important we tailor the polysomnography or the test to a specific problem. For instance, as you said, if one is looking at narcolepsy, then what really one wants is to have a night sleep prior to the MSLT, so that you know that the sleep before the MSLT was okay, and you're able to.
Sorry, audio has disappeared again.
Oh gosh. And now
Yes, now.
I'm there.
Yes.
Okay. So I was just mentioning. So if you are, say, for example, if you're doing narcolepsy, you want an overnight sleep followed by MSLT. If you are thinking of somebody then who is having sleep-related breathing disorders, then you want to tailor that test towards breathing. So you need to monitor all the respiratory parameters that may be required. So I was just going to the polysomnography is a test that is best tailored to the specific problem of a particular person. So
We've lost you again.
yeah, there you go again. And now?
Yes, now we can hear you.
Yes. So if say you're doing a REM sleep behavior disorder, then one want to mentor specific EMGs to be able to do that and be able to quantify REM sleep at night. So it is important that we do some model that actually tailor it to a specific problem. The other thing I was going to mention about kids, of course, is that often some problems that present sleep disorders may actually not be sleep disorders. For instance, children with nocturnal frontal lobe.
Sorry, you keep disappearing.
Oh God. Okay. So and now?
Yes, now.
I think I've got problem with my mic.
Yes.
Yeah, so I was saying, so children who present with what looks like sleep disorders may
Yes.
actually be having other problems like epilepsy. For example, frontal lobe, seizures may very well present as a nocturnal arousals, a confusion arousal. So again, it is important that not only do you do a polysom, but do a polysomnography that can also be able to answer the question of seizures. So it is increasingly
Sorry, we've lost you again. Are you talking from the Bluetooth? If
No,
it's
I think I've got a mic which I think is kind of not, is a bit dodgy.
okay, yeah.
Yeah.
Can you do without it?
I not quite, unless I log in on a different thing. Can I try that?
Yes,
Can
I
I log in
think,
somewhere different?
yes, I think you can try that.
Give me just a minute. So I try see if I can log in with something different.
Okay, as you do that, I'll try and answer some of the questions that are saying. So when a child sleeps, or even an adult, and can plan what you want to do the following day and recall it when fully awake, is that a sleep disorder? Is there treatment for such a case? I don't think that's very clear. I don't think I'm getting this very clearly, but yeah, sometimes we do tend to think a lot before we go to bed. I don't think that would constitute a sleep disorder. What would constitute a sleep disorder is if you're having vivid dreams that perhaps you're acting out, or parasomnias. My 17-year-old son is having difficulty in sleeping for the last 3 years since he went to boarding school. Last week, he came home with a suicidal attempt due to poor grades, due as a result of not being able to concentrate in class. How can we help him? He has been put, a toxicology screen is negative and has been put on Cipralex, which is an SSRI, selective serotonin reuptake inhibitor. So again, we mentioned that selective serotonin reuptake inhibitor would contain serotonin, and serotonin, we said, is one of the neurotransmitters that help a child stay awake. So this child, we talked about the 4 things that you need to do. You need to keep your sleep diary. You need to take an adequate history. This is a child who would benefit from going to Mudinji for a polysomnograph and actigraph, so that we can try and find the root cause of the challenges that the child is having with sleeping. Most likely, with a good history, we should be able to pinpoint what exactly is causing this child. And obviously, if this is a long-standing problem, it can result in suicidal attempts and poor grades. So I think we definitely need to see this child so that we can take a further history and assist this child. I don't know if Mudindri is back.
Can you hear me now?
Yes, we can hear you.
Okay. Where was I? So I'm having an echo again, haven't I?
Yes, but we can hear you.
You can hear me.
Yes.
I was saying, when we have children who present with what looks like parasomnia, it is important that you also consider possibility of other things like epilepsy. And I was mentioning nocturnal frontal lobe epilepsies are not uncommon in children, and they may present like parasomnias. What was I going to mention? So as I said, obviously, when you do polysomnography, it is important you consider what the question is so that you can add parameters that would be able to answer the specific question, which is relating to the problem of specific patient. So if you only do a polysom with the 3 entities of EMG, EOG, and ERG or EOG, then obviously you may only be able to tell the sleep pattern or sleep architecture of that particular patient. So if somebody was having a obstructive sleep apnea, then you need to concentrate on parameters that deal with issues of breathing. If you are looking at somebody with REM sleep behavior disorder, for example, then you need to monitor not just the EMG, which we monitor the chin for sleep staging, but also monitor other EMGs in the limbs, both upper and lower limbs. It's also, children who may have restless nights have also been known to have positive periodic limb movement disorder. So again, if you have that kind of a patient, you'll need to monitor the limb so that you can quantify the limb movements. So those are just a few comments that I wanted to make about the presenter, which you have really covered very well, and you covered a lot of ground on it. Thanks.
Thanks. Maybe Mudinji, you can tell us, because I think some people are asking where they can access the polysomnography in Kenya.
Yeah, okay. So at the moment, perhaps I know Nairobi Sleep Clinic in KNH-UoN, they are doing decent sleep studies. So that's one place one can have this done. Brain and Nerve, where I work also, we do sleep studies. We are in Upper Hill at KMA Center. I am not quite sure of others. I know Nairobi Hospital was starting, but I don't know whether they have really moved, and Aga Khan also wanted to start. I don't know how far they've gone with it. But I know those two centers are now doing sleep studies.
Okay. I think there are some people who've requested for your contacts, so I'll share them. There's a question here, which Mudinje and I will answer. Someone is asking how to differentiate between a seizure disorder and a sleep-related body movement or parasomnic activity. I think
Sure.
the first thing is doing a good history and a physical examination. Usually, if the patient has a video of the event, it can assist you in knowing if that is actually a seizure. Remember, there are many things that look like a seizure that are not actually seizures. For example, what we call benign sleep myoclonus, where you'll find a baby who's asleep is having jerky movement of the limbs, and some people can actually think this is a seizure, but it's actually a benign sleep movement disorder. So doing a good history, physical examination, and then of course doing your supportive tests, like doing your EEG, would be able to help differentiate. Again, history and physical examination is important because we know that having an EEG that's negative for a seizure does not necessarily mean that this patient does not have a seizure.
Just to add that, Dr. Molo, yes, that's very, very true. So you have a child who has events at night, and the question is, are these events a sleep disorder or is it epilepsy? Again, the gold standard for epilepsy is really be able to capture an event on the video, but also be able to capture that synchronously with EEG. A routine EEG will not give you any useful information, but having a video EEG is really the gold standard for that. So then how do you differentiate a sleep disorder and a seizure? It is having what we'd call a video EEG recording. And this EEG is not just the 3 channels that monitor the sleep, having a comprehensive EEG with all 21 electrodes on the head. Usually that is a good standard for differentiating epilepsy and sleep disorder. So comprehensive video EEG recording.
Thank you. There is a question here also about if there's a relationship between late night hyperactivity, either on social media, and intense exercise versus insomnia. Yes, I think we've spoken about this. We've answered and said that we know that using bright lights and using your telephone or social media late into the night is a contributory factor to insomnia, and also doing intense physical activity right before you go to bed can contribute to insomnia. Also overeating, sleeping immediately after eating, lack of fairly low pillow versus bad dreams. Yes, there's an association between your sleep environment and the quality of sleep that you have. So ideally, you should be in an environment that you're well covered, your mattress and your pillow are comfortable, the room is warm enough so that you can have adequate sleep. Usually, if you wake up in the morning and you're feeling that you're not quite refreshed, then likely it means that you have inadequate sleep hygiene. Your sleeping environment is not good. Here, they also ask if there's a relationship between self-hygiene, like brushing your teeth, showering of all essential openings, and bowel evacuation with sleep. I don't know of any association with sleep and those things that you have mentioned. There's a question here also on how do you manage a child with excessive body rocking? Usually this one, you just observe the child. However, if you feel that it's likely to cause self-injury to the child, you just ensure that the child sleeps in an environment that is safe for them. It's quite a challenge deciding on whether or not to put these children on medication, because we know all medications come with their complications. So the best approach would be a non-pharmacological approach before you opt for giving pharmacological approach. Most people with this rhythmic movement in sleep for the children, as they get older, then they usually tend to disappear. As I said, if you have a child who maybe has violent head banging, then you can look at safety measures such as putting a helmet on this child. Also, ideally, you should try not to wake these children up suddenly when they are going through these periods. Just make sure that the child is in a safe environment and let the child wake themselves up on their own. I think I've answered most of the questions. So if there are no further questions, I think I'll end the meeting here. Thank you, Mr. Mudinji, and thank you all who have tuned in. Again, I'll encourage you to ensure that you have a good night rest and ensure that you have good sleep hygiene, sleep when you're supposed to sleep, so that you do not suffer from any of these sleep-related disorders. Thank you for tuning in.
Thank you very much, Doctor.